CME requests. There's a lot of activities this month as we kind of go into the holiday season. But we have a few more grand rounds coming up with visitors from the Brigham and the University of Pittsburgh, which will be fantastic presentations. And I encourage you to all, come in person if you can. And there will be a series of meetings with these visiting faculty that hopefully many of our fellows and faculty will be engaged in. We'll have a break Christmas and New Year's, and then we have another visiting speaker which will educate us on cardio-oncology topics, Susan Dent, who's well known as well. Didn't know she was at Duke, actually. She wasn't at Duke when I was at Duke, but she's joined there. A reminder that we'll be sending out a hold a date probably within the next 24 to 36 hours for our winter gathering social event, which is January 20th in the evening for our faculty, fellows, and staff and their guests to come and enjoy some post-holiday, lower stress social time together. And so you'll please look for that hold a date and invitation, which you should be receiving shortly. And so is that, am I going to introduce Mike or, okay, Mike.
All righty, good evening, everybody. So it is my great honor and privilege to be introducing Dr. Ray Hu tonight for our grand rounds. So Ray completed his education at Princeton, Johns Hopkins, his residency at Vanderbilt before coming here for fellowship. Since he arrived at Yale, I've had the pleasure of mentoring Ray. And his performance has been nothing short of extraordinary. From an academic productivity standpoint, Ray has dozens of publications, including in top-tier journals like JAMA and Annals of Internal Medicine. Ray has completed a trifecta that I'm not sure we've ever seen in the Division of Cardiology, and that's receiving the Teacher of the Year Award from the medical students, the Fellow of the Year Award from the medical residents, and the Consultant of the Year Award from the emergency room. I don't think that's ever been done, so that's really impressive. It deserves a round of applause. So, but actually, the thing that impresses me most about Ray is his mentorship. So, he's the rare fellow that's actually taken on a number of junior colleagues to mentor them during his fellowship, which is, I think, really unique for someone at his stage of training. And then, of course, Ray has been recognized for his innovation in the space of digital tools to augment decision-making in cardiology. And his work has been recognized by a variety of national organizations, the Boston Globe Stat News Group, the American Society of Nuclear Cardiology, and the American Heart Association. So that's what he'll be talking to us about tonight. So I hope we all give him a warm welcome.
So I press end show here and go to this one. And I speak. Great. Good afternoon, everyone. I am excited to speak with you about building digital tools in cardiology for decision making. Starting off with stress tests. There's high variability in overuse, underuse, and misuse of cardiac testing for ischemic heart disease. Now, everyone in this room knows that appropriate use of cardiac testing, including cath, may reduce unnecessary radiation exposure, patient risk, and adverse economic impact to patients and society. Many specialty societies have put together appropriate use criteria, or AUCs, but although these are carefully constructed, AUCs have had limited uptake in practice due to discrepancies in scenarios and definitions across different society documents, the sheer number of scenarios, the multimodality nature of stress imaging, and the flat nature of PDFs, which are hundreds of pages long. For example, in this 2014 multimodality AUC for stress imaging, it does not distinguish between SPECT and PET. It does not distinguish between exercise SPECT and regadenoson SPECT. And within stress echo, It does not distinguish between exercise stress echo and dobutamine stress echo. It's difficult for us to expect our non-cardiology colleagues to know every detail when our own AUCs do not specify the distinction. Another problem is that some societies will enumerate extremely detailed scenarios with AUCs for these detailed scenarios, which you can see here for PET stress tests, but these scenarios are not covered by the other societies. We wanted to create an interactive scenario-based tool for clinicians to receive instantaneous feedback on whether the stress test they are planning to order for their patient is always appropriate, maybe appropriate, or rarely appropriate for 10 modalities. This required harmonizing all AUC documents for stress imaging and developing a rule-based imputation for non-specified scenarios, i.e., the scenarios specified by some societies' guidelines but not by others' guidelines. This was an arduous undertaking by Camilla, Kate, Caro, and Mara with the help of Drs. Feher and Miller. Throughout the presentation, I'm including photos of the individuals involved because these individuals have devoted uncountable hours in either coding, flowcharting, data collection or adjudication, or design or editing, and I want others to recognize their essential contributions. You're probably familiar with the Choosing Wisely campaign of the last decade, and I thought we need a Stressing Wisely campaign. So we bought stressingwisely.org, which is now live. To accomplish this, we constructed a menu of options that reconciles the definitions used across different society documents, including symptomatic and asymptomatic reasons for investigating, prior revascularization, typicality of symptoms, cardiovascular risk factors, age group, ASCVD risk score, result of initial cardiac testing, and preoperative characteristics if applicable. For each scenario, we inputted the rating of the most recent applicable guideline, the rule used to arrive at that rating, and the evidence document and table associated with this. We repeated this process for 2,186 scenarios. In the next step, we created comprehensive matrices consisting of feature scenario keys, scenario rating keys, and rating justification rule keys. Each rating and rule is associated with an evidence document and a specific table from that evidence document. All the ratings were performed by a pair of cardiology fellows and reviewed by a pair of cardiac imaging attendings in a blinded manner. This table shows the resulting distribution of appropriate, maybe appropriate, and rarely appropriate ratings, with 11 different testing modalities, including CAC, coronary CTA, invasive angiography, and no test. We made 24,000 ratings with 96,000 possible permutations. Using R, Shiny, JavaScript, PHP, and SQL, we coded a graphical user interface for clinicians to interact with the unified guidelines. Clicking on the book icon reveals the definitions to the user. Let's say we have a patient who has anginal symptoms, no known CAD, atypical angina, 2 or more cardiovascular risk factors, age 72, who just had an exercise treadmill test that was mildly abnormal. The user can also pick from a menu of contraindications, which we weave together from 5 different society guidelines. I'll pause this right here. So when you generate the results, it's going to say, here we have a scenario where there's a more than 50-year-old symptomatic patient with no known CAD with atypical angina, 2 or more risk factors with prior abnormal exercise treadmill test, no Duke score specified. So it's going to tell you exercise treadmill test is not applicable for indication because you already did it. Exercise SPECT is appropriate for indication. Farm SPECT is appropriate for indication, but it's contraindicated by the caffeine ingestion in the last 24 hours. And for every single one of these, clicking on the link icon will take you to the specific table and guideline with which we source this thing from. In this other example, you see that in a patient who is low pre-op risk, that almost every modality is rarely appropriate. So these are just 2 examples of how this tool can provide a comprehensive assessment of multimodality imaging for coronary artery disease. So how does this compare to what we currently have? Currently approved CDSMs, or clinical decision support mechanisms, are optimized for billing and hospital profits, not for patient care. You've seen this screen whenever you try to order radiologic tests of any sort. Current citation for an imaging test order so that the imaging test can be billed and covered by insurance. These CDSM systems do not make any effort to change the mind of the ordering physician about the appropriateness of the test being ordered, nor do they suggest alternative tests that are more appropriate. In contrast, in our reverse approach, Stressing Wisely provides appropriateness ratings for a range of imaging and non-imaging cardiac tests, including the option of no test, so that the ordering physician can make an informed, guideline-supported decision about the right test to pursue for the patient. Therefore, Stressing Wisely represents a successful prototype in which a computational approach can weave hundreds of pages across different society guidelines with discrepant definitions into a point-of-care educational tool that addresses a quality gap. Moving on from stress tests, we commonly get consults for GDMT, including uncertainties about which GDMT medications can be started at which stage of kidney disease. Therefore, we created GDMT for Everyone, which anyone can visit at gdmt.org. Patients with heart failure and reduced ejection fraction and CKD or ESKD are a vulnerable population. They face triple threats. First, CKD or ESKD is an independent mortality risk factor in heart failure. Second, over half of randomized controlled trials in cardiology exclude patients with advanced CKD or ESKD. And therefore, these patients are less likely to receive GDMT medications approved for their stage of kidney disease. Full GDMT is prescribed in only 25% of CKD3A patients, down to 3% of ESKD patients. In the Biostat CHF study, presence of CKD was the most commonly cited reason for not up-titrating GDMT. So if you visit www.gdmt.org, you'll be able to see a summary of every GDMT agent and GDMT adjacent agent and a quick summary of what is allowed at each stage of CKD or ESKD. Clicking on a specific cell will bring up direct quotations from the ACC, AHA, HFSA, and KDIGO guidelines about what can and cannot be done. Clicking on that medication name itself will bring up guidance on dosing of that medication, such as the ASCVD risk equations here. As I mentioned, this tool is grounded in the recommendations from the 2022 HFSA guideline for the management of heart failure, as well as associated guidelines from KDIGO. Now, to take things a step further, if you were a primary team, you could say, well, my patient is on lisinopril, metoprolol, spironolactone. It's going to tell you to switch to Entresto. It's a class 1 recommendation. So you do that, then it's going to keep on telling you to up titrate to maximal dose. You want to start an SGLT2 inhibitor, and now let's say your ferritin is low. It's less than 100. It's going to tell you to replete the iron. It's a class 2A recommendation. Now, if we give the person an AKI, it's going to tell you to hold everything except the beta blocker. Now, if we uncheck everything and take this patient to HFpEF, we can now say that there's a class 2B and 2A recommendation with the MRA and SGLT2 inhibitor. And when you change it to HFmrEF, it now adds in the 2B recommendation for the beta blocker. Who uses GDMT for Everyone? According to Google Analytics, GDMT.org regularly receives users from around the world, and it's the most popular among internists and cardiologists. It's widely used by residents, fellows, and attendings. Great, so moving on from GDMT. Another very common consult question is the consult for asymptomatic troponin elevation. In a small survey of cardiologists and cardiology fellows, including people sitting in this room, 90% agreed with the statement, I have seen situations in which serum troponin is ordered in the absence of anginal symptoms very frequently or frequently. 87% agree with the statement, I have seen situations in which serum troponin is ordered when there's no presenting cardiac issue very frequently or frequently. This is not a local issue, but an issue everywhere. A study in JAMA Internal Medicine found that serum troponin testing is performed in 47% of inpatients, including 35% of inpatients without anginal symptoms. In our survey, 61% reported seeing situations in which inaccurate interpretation of serum troponin has led to billing of unnecessary services very frequently or frequently, and 82% reported seeing situations in which inaccurate interpretation of serum troponin has led to unnecessary additional testing very frequently or frequently. Therefore, we decided to create, for fun, the Foundation for Responsible Use of Troponin. which we are launching at www.troponin.org. On this tool built by Claudia and Scott over here, you can input the first and second troponin values and select the assay used. At Yale, it is Roche, and the elapsed time for Yale is 60 minutes. The app will tell you that for this particular pair of troponin values, it has a sensitivity of 83.8% and specificity of 91.9% for ACS. You can take it a step further and input features gathered from your HPI. With the chest pain's worth on exertion, it carries a PPV of 18 to 21 for ACS and a positive likelihood ratio of 1.5 to 1.8. Similarly for T-wave and other ECG features. You can expand this for any number of features and it'll provide you with the LRs and the PVs. Now, let's say you have an echo that comes back normal, the CTA that comes back normal, and you're trying to reassure yourself that this patient's fine. The absence of features can also be handled and carries its own negative likelihood ratios, as you see here, LR negative and negative predictive values. As a user, you can customize whether you want to get likelihood ratios, predictive values, sensitivity or specificity, or all measures. Where did we make up these numbers? We didn't. These numbers came from Compass MI, a study of high sensitivity troponin trends in 15 international cohorts, and from JAMA Rational Clinical Exams, meta-analysis of what each aspect of the HPI signifies with respect to ACS. These are validated diagnostic measures. All we're doing is designing interactive tools to bring them to the point of care, and that is our focus. Now, because we receive so many questions in the hospital about high sensitivity troponin, we undertook an extensive writing and illustration effort. On troponin.org, you will find useful information about the generations of assays, analytical and clinical sensitivity and specificity, updated terminology about myocardial injury and infarction, journal club summaries of key troponin papers, and clinical case vignettes of how to interpret troponin in different settings. But does this work? To find out, we rolled out the Troponin tool and educational portal at morning reports across the York Street campus, St. Raphael's campus, Bridgeport, and Waterbury. We asked residents and medical students their level of confidence in providing definitions to distinguish between the following terms before and after the use of the Troponin tool and educational portal on the left and right, respectively. Red indicates completely confident, purple indicates fairly confident, and blue indicates somewhat confident. Green is slightly confident, and yellow is not confident at all. You can see that whether it was for myocardial ischemia, injury, infarction, or type 2 MI versus type 2 NSTEMI, or high sensitivity troponin versus fourth generation assay, there was significant improvement after the educational intervention. Similarly, we asked residents and medical students their level of comfort in interpreting troponin elevations in the setting of impaired kidney function, physical trauma, immunotherapy, and a dozen of other conditions before and after the use of troponin tool and educational portal. Red indicates very comfortable, purple indicates comfortable, blue indicates neutral, green is uncomfortable, and yellow is very uncomfortable. Once again, there was an impressive improvement after use of the tool and portal. Therefore, this approach may be useful to medical educators in other specialties hoping to create digital tools to integrate diagnostic test performance measures into point-of-care clinical education. We're past midway through our time together and have covered the design of Stressing Wisely, GDMT for Everyone, and Troponin Toolbox. Now I would like to give you a preview of several other tools that are in the pipeline. On the consult service, we are frequently confronted with pericardial effusions and pressured by primary teams to put a needle to drain any sort of collection. However, there is a lack of appreciation among other services that pericardiocentesis is not a procedure without its own risk, and an insufficient understanding of the criteria for deciding if somebody with an effusion is in tamponade. Therefore, we designed the Tamponade Toolbox, which you can visit at tamponade.org. When you go to tamponade.org, you'll be able to see descriptions of RA and RV diastolic collapse, LA collapse, plethoric IVC, and all echo images can be viewed with or without annotations. All images are from real echoes at YNHH. You can also see an example of hepatic vein flow reversal. In addition, you can see information about physical exam findings of tamponade and images of what happens when pericardiocentesis goes wrong to discourage teams from pressuring us to reflexively tap all fluid collections. In the next few months, we'll be undertaking a large effort to chart review all pericardiocentesis at YNHH in the next 5 years to generate predictive values and likelihood ratios and prevalences for each sign, so we can design an evidence tool akin to the Troponin tool. Moving on from tamponade, this is a very exciting time for cardiovascular prevention. With the wealth of therapies coming through phase 2 and 3 trials, with the speed that these are becoming available, it can be confusing to figure out when someone qualifies for addition of any therapies beyond the standard statin and ezetimibe. Therefore, we designed a TheraPrev, a tool that helps clinicians decide which non-statin therapy they can use next. I was very happy to be able to get ascvd.org. This ASCVD tool, which is still in its early stages of development, allows the clinician to input patient characteristics and receive information about whether they're eligible for inclisiran, bempedoic acid, PCSK9 inhibitors, or icosapent ethyl. It also helps the clinician figure out whether Lp(a) level is indicated. Taimur and Bashar have really taken the lead in not just coding, but systematically compiling all the non-statin trials in existence. Where did we get the evidence? This tool is grounded in the recommendations from the 2022 ACC Expert Consensus Decision Pathway and the role of non-statin therapies. In addition, it will also calculate the 10-year ASCVD risk based on a new PREVENT set of equations that were just released at AHA last month. Moving on from ASCVD, another common consult we get is to help with bread and butter AFib. Therefore, we designed the AFib Assist tool. AFib.org and atrialfibrillation.org were taken. So Camilla had the bright idea of suggesting we get atrial harmony. The atrial fibrillation tool will have modules to assist with its estimating bleeding risk and the decision to anticoagulate, selection of rate control agent, selection of rhythm control agent, control of rapid ventricular response, and thanks to Dr. Freeman, Watchman referral. In this wireframe of the RVR module, the clinician can input the oral and IV medications that they have used to treat AFib in the last 24 hours, as well as acutely during the RVR episode, and the tool will provide recommendations on reasonable next steps based on parameters such as blood pressure, serum creatinine, and structural heart disease. This tool is being tailored to the AFib guidelines from the HRS, ACC, and HA that were just released last week. Moving on from AFib, another consult question we often receive is what to do with patients who are receiving chemotherapy and immunotherapy who are at risk for cardiotoxicity. Therefore, we designed a digital tool to assist clinicians with figuring out screening and monitoring for any combination of cancer therapies and patient risk factors. This app also offers a dark mode, a nice touch by Ruben. So let's say you have a patient on BCR-ABL inhibitor by the name of imatinib. They have a BMI of 31, diabetes, are 62 years of age. This patient, let's say, also has heart failure, abnormal ankle brachial index, and arrhythmia, and a QTc of 470. They have an elevated troponin and EF under 50% and receive anthracyclines in the past. Give it a second to think, and we'll provide you with the following color-coded class 1 and 2A recommendations from the ESC. It will tell you that this patient needs an echo and physical exam at baseline 3, 6, 9, and 12 months, but lipids, A1C, and ECG at baseline only. It will also give you the prevalence of each cardiovascular adverse effect so you know which entity to watch out for. Where did we get this recommendation? As I mentioned, this tool is grounded in the recommendations from the 2022 ESC Cardio-Oncology Guidelines developed in conjunction with the International Cardio-Oncology Society. So we have covered a lot of ground in the last 20 minutes. Through these examples, I hope you can get a sense of the process, which is invariably sparked by an idea that arises from a clinical problem. What starts out as a paper sketch is mapped out to account for possible clinical scenarios in a structured manner. For each scenario, we specify the recommended behavior, the rule used to arrive at the recommendation, and the associated guideline that the rule is grounded in. We design logic flowcharts to outline how the application should decide what to do, and wireframes to visualize how the application should interact with the clinician. Then the coding and debugging begins. We try our best to provide accompanying educational material in the form of tutorials and infographics to make the website a one-stop shop as an educational tutorial. We then assess the impact of the educational intervention on learners alongside its public release. At every step, the plan is dynamically revised based on feedback on consensus. I also want to give a shout out to Dan, Scott, and Claudia for this recently published review article on digital tools and decision-making in coronary artery disease. Before we end, I want to make it known that no stock photographs of actual patients or physicians were used. All faces were generated by AI, except the faces of team members. These were not enhanced by AI. I'm grateful to many other faculty and fellows not listed here who have indirectly championed the development of these digital tools. There are many pathways for further development in various stages of discussion. To summarize what we've seen in the last 23 minutes, many aspects of decision-making on the cardiology consult service can be modeled computationally. Use of these digital tools can improve clinician understanding of cardiac conditions and can bring guidelines to the point of care. This approach may be useful to medical educators and other subspecialties hoping to create digital tools. Whether improved clinician understanding leads to downstream outcomes, such as reduced unnecessary stress tests, should be evaluated in future work. So with that, I want to thank everyone in the audience and on Zoom, and a huge thank you to all the members of the building teams. I will now turn the podium on time over to Dr. Pyus.
All right, so this is really my honor and privilege to introduce the next speaker, Jackie Pyus. So Jackie obtained her BA in biochemistry and molecular biology from Reed College. Then she attended the University of Massachusetts Medical School in the clinical and translational research pathway, where she spent time studying human adipose tissue development and its relationship to whole body insulin resistant and type 2 diabetes. And then she went on and she was accepted into the NIH and Hobart Hughes Medical Institute Joint Medical Research Scholar Program, where she spent a year with Richard Yule and trying to understand the innate immune system's role in mitochondrial dysfunction via in vivo mitochondrial DNA bioengineering manipulations. And after the medical school, she completed her internal medicine residency at WashU in St. Louis, where she continued to work on research, and she was the recipient of the Knowlton Award given to final year residents final residents for advocacy, compassionate care, and dedication to the science of internal medicine. And I'm sure that those of you who know Jackie well would agree that Jackie is a really smart, compassionate person who deeply cares about patients, who really thrives in a collaborative environment. So I think it was natural for her to choose this field of cardiorheumatology. And today she's going to talk to you about atherosclerotic disease, coronary artery disease in rheumatoid arthritis. Jackie, take it away.
So, I met someone who would become my patient. For all 3 years of residency. He was misdiagnosed, unfortunately, with scleroderma, and then my third year of residency, realized that he had NSF. And he ended up inpatient for about a year, getting photophoresis. He was in the ICU for about a year, and he passed, actually my 3rd month here. And his wife has my phone number, she still does, and she texted me. I woke up to the text, and she just said, "Thank you so much for everything that you did for Randy." And I felt very frustrated, because as I was taking care of Randy, and I asked his wife today if I could share this story, he had so many other risk factors, but everybody focused on, of course, the big factor was the disease that made him stay in the ICU for a year. He ultimately actually died of an MI while he was in the ICU. And I remember a conversation I had with Randy, called me Doc, and he came into clinic my 2nd year. And I staffed him with Brian Gage, who discovered or first described the CHAD score. And I told Randy I needed him to be on a statin. And he asked me why, because he was already on so many medications. And I went on a rant to Randy. He and I ranted to each other. But I went on a rant to him about my concerns. And earlier this year, another patient that I love very dearly that has rheumatoid arthritis comes to my clinic for palpitations. I asked her to go on a statin. And she said, why? And I thought, well, you have rheumatoid arthritis. I thought it was so simple. And she said, what's the connection, Dr. Pyus, to coronary artery disease? So I thought, she's actually on this Zoom call. So I hope that this is educational for her. And I have a couple of other patients that I also invited to be on this grand rounds. So I want to start by, and all my slides are all over the place, but I want to start with making a statement to all of you here. Heart disease is the most frequent cause of death worldwide. To that end, we have identified traditional risk factors for cardiovascular disease over the last 50 years, and we included them in various clinical prediction models for the hopeful prevention of cardiac morbidity and mortality. Over the past 20 years, however, chronic inflammation has emerged as a non-traditional risk factor and actually an amplifier of heart disease. And the most well-characterized autoimmune disease establishing the link between systemic inflammation and cardiovascular disease is rheumatoid arthritis. You've all already seen this slide because Attila clicked forward, but RA is a symmetrical polyarthritis. It's the most common autoimmune arthritis in the world. It's a prevalence of about 0.5 to 1%, which is roughly about 1.5 million patients in the United States. The inflammatory process is systemic, and it may lead to several extra-articular manifestations. Of all of these manifestations, cardiovascular disease is the most critical in these patients. Cardiovascular disease in patients with rheumatoid arthritis can be divided into 3 main categories: atherosclerosis, thromboembolism, and cardiac dysfunction. I would love all of the time in the world to talk to you guys about all of the manifestations, but I'm going to solely focus on atherosclerosis here. And I'm going to be even more specific in that we're going to solely focus on epicardial atherosclerosis. And I can't do a talk on RA without sort of showing the classic articular manifestations. So what you're seeing at the top is the ulnar or orno drift of the MCP joints. And then here in the bottom panel, you're seeing what's called classic swan neck deformity. That's on the 4th digit. And that happens because of hyperextension of the pips and then hyperflexion of the dips. So it can be very debilitating to condition. And the last one that you're seeing on the pinky is called the boutonniere deformity on the 5th digit. So we've known about rheumatoid arthritis for about 70 to 80 years. But it wasn't until this hallmark paper in the field of rheumatology by Cobb et al. That we realized that there was actually a death sentence associated with this condition. So this was 1953. So these are not Kaplan-Meier curves. These are life tables. So this was data on 583 patients that were hospitalized at Mass General Hospital. And at that index hospitalization, they were diagnosed with rheumatoid arthritis. And so the question was, what happens to these patients long-term? So they naturally followed the patients after that index hospitalization and index diagnosis. And what you can see, especially for some of my patients who I know want me to walk them through this, it's the top line is expected death in the normal population. They had about 1,000 healthy patients. And the bottom line, the solid line, is what actually happened. So expected over observed, or the second line is observed. And what you can see here is that there's a clear difference between the 2 lines. So if you were diagnosed with rheumatoid arthritis before the age of 25, and if you were diagnosed with rheumatoid arthritis between the ages of 25 and 49, you live about 20 years less for this data. What they showed was that there was an increased mortality by 2 to 3-fold. So some of you listening are going to say, well, that was 1953. We didn't have medications for rheumatoid arthritis. We didn't treat chronic inflammation back then. So what's the mortality for rheumatoid arthritis today? Well, this is from 1994. I know it's not today, but this is from 1994. And you can see the same high mortality trends. This was This wasn't Solomon at all, but essentially they had 4 different populations, including in Canada. So you can see Saskatoon is a region in Canada, and they recruited patients, I think it was between 1955 and 1990. Again, it's the same story, but it's a little bit more interesting because they separated the gender. So again, the top lines are men and women without rheumatoid arthritis, and the bottom lines are men and women with rheumatoid arthritis. And these are Kaplan-Meier curves for those that were curious. And this SMR that you see them writing within each graph stands for standardized mortality ratio. And what that is the ratio of observed to expected number of deaths. So let's take Saskatoon, Canada, for example. So if you are a patient, a man with rheumatoid arthritis, and you were, let's say that's 1980, you lived 17 years less than men that did not have rheumatoid arthritis. Okay. So I know you're going to say, maybe that data is slightly old, Jackie. You showed us a 1953 paper, and then you showed us a paper that was published in 94, but the recruitment happened between 1955 and 1995. This data has been replicated over and over and over again. And most recently, the Dutch group, they're very, very prominent in the RA world. They reproduced the same data that was published in 2015. So this is data from, I think most of us are familiar with the Nurses' Health Study. So the Nurses' Health Study began in 1976, and they had 100,000 registered nurses that completed a questionnaire about their medical history, cardiac risk factors, menopausal status, and lifestyle factors. And then they followed the cohort. Every 2 years, these people would receive a questionnaire, and they would inquire about new medical diagnoses, for example. And they continue to inquire about lifestyle. So menopausal status, are you taking vitamin D, vitamin E? Are you smoking? How much are you smoking? And these patients were followed for 40 years. There were 527 incident cases of rheumatoid arthritis in this cohort. It was actually 122,000 registered nurses. So that's pretty similar to what I told you in the first slide, right? 527 divided by 100,000, you have about 0.5 to 1% incidence. So numbers are still pretty stable in the realm of rheumatoid arthritis. So 527 incident cases, 3,600 myocardial infarctions and strokes in those. And what did they find? And I think I circled this for you, but they found that women with rheumatoid arthritis have a 2-fold greater risk of myocardial infarction compared to women without RA. That's like diabetes. 2-fold. And they went even further and they said, well, what if you've had rheumatoid arthritis for a long period of time? What if you've had it for more than 10 years? Those women had 3-fold greater risk of myocardial infarctions or strokes. Okay, so I'm very passionate about this, if you can't tell. I was told to not show passion, it's hard. so we've been working on, Attila and I, though he's, I'm sure, waiting for the manuscript. We presented this at ACC this year. That was March. I'm not as productive as Ray. And so these were patients with rheumatoid arthritis who underwent any nuclear testing between May of 2016, August of 2016, and May of 2021. And then we retrospectively studied and compared with control patients. So control patients were matched to RA patients. I believe we did age, sex, comorbidities, and stress modality. And we did a median follow-up of around 3.5 years. So you're sort of looking at this and you're saying, okay, Jackie, but that's not new. You already showed us that women with rheumatoid arthritis have 2-fold. These are not relative risks, by the way. These are hazard ratios, but similar concept that patients with rheumatoid arthritis have an independent risk factor. So we adjusted for all risk factors, and they still stood out as if they've had ischemia before, or actually more than the diabetics, or slightly less. Interesting. Okay, in the era of statins. And then we went further and we evaluated the association between rheumatoid arthritis diagnosis, ischemia, and a composite endpoint mortality of mortality or myocardial infarction with survival analysis. So I know all of your eyes are going to go to the bottom. I know that's where everybody's going to look. My husband's a catheter, and that's where his eyes looked. And he's like, well, no difference. But that's not the point of this graph. The point actually is the people without ischemia. So the RA patients who came into the nuclear lab at Yale, and we said no ischemia, carte blanche, everything is okay. And somehow they still died or did poorly compared to the patients without ischemia. This is our own data. Okay, so what's the difference? So if apples to apples, atherosclerosis to atherosclerosis, why are these patients dying younger? And why do they have more atherosclerotic disease? Why do they have a higher burden? This is from 2007. This is from Shireen. I don't know if anyone knows Shireen Gabriel. I don't know her, but she's very productive in the space. So unfortunately, we do not have a lot of histological studies of patients with atherosclerosis and rheumatoid arthritis. This is still only one of 2, 70 years into doing research in RA. And so this is very interesting because what they did was, this was a post-mortem, so retrospective post-mortem population-based study. So patients, their bodies, after they passed away, were identified by having RA, and they matched them to someone without RA. These patients died of myocardial infarctions. They went in, they dissected the coronary arteries, and it was sort of a, what are we gonna find here? And I think these are, I think, the most powerful graphs in that paper. So let me sort of walk you through this. So grade of stenosis, I think that's pretty self-explanatory. And it's very similar to how we read coronary CTAs here. So grade 1 would be that you have minimal, what we call minimal stenosis in the CT lab. So that would be 0 to 24%. Grade 2 stenosis would be that you have mild stenosis. So that would be 25 to 49%, and so on forward until you get to severe stenosis. What they called extent of atherosclerosis was you had to have in the vessel, the LAD, the CERT, you have to have more than 75% of stenosis to be considered severe extent. And then in order for you to be called multi-vessel disease, you have to have 2 or more vessels that have disease. And the left main is greater than 50% stenosis, but you get the gist. And I think this is very powerful. I want you to burn this in your brains every time you see a rheumatoid arthritis patient. Look at how many patients with rheumatoid arthritis had what they call 0 extent of atherosclerosis. These people died of myocardial infarctions, and only 32% of them had multi-vessel disease. Look at the grade of stenosis. Most of the patients had, the non-RA patients had significant stenosis in the LAD, for example, right? If you look at the LAD, most of the patients, the non-RA patients, had stenosis. That makes sense. They died of an MI. Not many RA patients had significant stenosis. So now I want you to start thinking, well, what is going on? What's happening? So they went further and they said, let's classify the plaque. So we have these coronaries from these patients that passed of an MI. Let's go and look at this plaque. So what they did was they wanted to classify plaque as vulnerable, like you're about to rupture, or you're stable, we have time. So the way they labeled that was if plaque had a fibrous cap, and this is, I think everybody does this in research, if you have a fibrous cap less than 65 micrometers thick, and you have more than 25 inflammatory cells, they called that plaque vulnerable plaque. Guess what they found? They found that patients with RA had more vulnerable plaque. So they didn't have multi-vessel disease. They didn't have significant stenosis. So how can we catch them when we do our ischemic evaluations, right? Back to the graph. I'm not going to get through the slide. I'm not going to spend as much time as I wanted because I have so much I want to show you. But this is again out of Mayo, out of Shireen Gabriel's lab, where she said at her own day, she said, well, how are these patients presenting? Are they presenting differently? Why are we not catching them? And so they found that patients with RA are less likely to have angina. Interesting. They're more likely to have unrecognized MIs. And they actually wrote in the paper, the number of EKGs done on both populations were the same. So it's not like we weren't doing the formal workup for the patients. So then we get to 2018, and the ACC and AHA says, okay, this is bad. These patients have bad disease, under-recognized. This is how we're gonna fix this. So what they did is they said, it's a heightened risk. So cardiologists, primary care doctors, if you see these patients, it's a risk enhancer. So put them on a statin if they meet criteria. So I'm not here to tell you what to think, but I just want everyone to think about whether you think this is enough or not. The European League Against Rheumatism, they went a little bit further, as they usually do, and they said, well, the data is sort of dramatic, so why don't we multiply? Why don't we, if you calculate a patient's risk, multiply it by 1.5, and then make your clinical decisions. So what does that mean? Let's do it together. So let's say that I have a 63-year-old woman. She's a smoker. She has an LDL, total cholesterol of 7.5 and an HDL of 1.5. So the Europeans use total cholesterol to HDL ratio. So that gives her about a 5. So let's do it together. We're all in clinic. So she is 63. So she's around here. She's a smoker. And today her blood pressure in clinic is 165. So we're going to walk over here. So 63, the ratio is 5. I'm going to go up here. Okay. So about a risk of 7%. And for my patients listening to the talk, what that means is that these are clinical prediction models that we use. And if your risk, for the Europeans in this case, if your risk is greater than 10%, it means that you have a risk of cardiovascular morbidity and mortality of 7% in the next 10 years. So they tell you to multiply it by 1.5. So if you do, it's 10. Well, that does make a difference, right? Because the Europeans say if it's not greater than 10, don't treat. In this case, now she gets her statin and she goes home. Is it enough? So for a long time, people thought, okay, so we know traditional cardiovascular risk factors. It's hypertension, it's obesity, it's smoking, it's diabetes, we know. So the only thing that's probably happened in rheumatoid arthritis, they have a little inflammation, so it's probably modulating the traditional risk factors. You take more NSAIDs because your joints hurt, well, that's going to give you hypertension. Your joints hurt, you have disability, well, then you're going to be physically inactive, right? So the thought process was, it's just the usual thing, right? A little bit higher, maybe. Okay. So this is what actually is going on in RA patients. So they do smoke more. No one can seem to understand why. They seem to smoke more than the general population. They do have more metabolic syndrome. And some people say, well, they're more sedentary, the joint pain, maybe that's what's going on here. They do have increased insulin resistance. They don't have hyperlipidemia. They have dyslipidemia. I'm going to skip these slides because I'm already at 22 minutes. I was going to give you guys a long, boring talk on atherosclerosis and foam cells and oxidized LDL, but Ray had a cool thing, so I don't want to take it back to the bench. So what I do want to talk about, because I was going to give you another talk about lipid biology, but I won't do any of it. What I'll say is that be careful with cholesterol when you order them on your patients. So there's something called the lipid paradox. Those of us that take care of these patients are very familiar, but what does that mean? The lipid paradox of rheumatoid arthritis. And it was first described in rheumatoid arthritis and now being ascribed to other autoimmune disorders. Well, here's what we know. We know there's an increase in cardiovascular risk with increasing serum cholesterol. That's easy, right? Your LDL is 200, you're at a higher likelihood of having an MI. Okay. In fact, in the general population, there's a linear logarithmic association between total cholesterol and cardiovascular risk. So that's not what happens in rheumatoid arthritis. Okay, I'm going to show you what happens. This is what happens in rheumatoid arthritis. This is the lipid paradox. These patients with the low total cholesterol are the patients having active disease and are the patients that are the highest risk of cardiovascular mortality. These patients. And there's a lot of data that shows that when you treat these patients and their levels of inflammation go down, that we can monitor with CRP and ESR, their cholesterol actually gets higher. Their LDL gets higher, their HDL gets higher, their total cholesterol goes up. So these patients are the patients in your clinic that need to make you nervous. These are patients with active immunoinflammatory conditions at high risk of MIs. And this is another image that I thought was nice from a recent review that essentially shows the same thing, the lipid paradox in rheumatoid arthritis. And if I had more time and we could do the lipid biology talk, taking me back to the bench, then I would explain why that happens, but we don't have time. So I guess what I'm trying to say is that rheumatoid arthritis is a heterogeneous disease with a range of outcomes for joint disease, and the same variability is likely to apply to cardiovascular outcomes. A number of studies have found that risk of cardiovascular mortality is particularly increased in seropositive patients, those with extra-articular manifestations, such as nodules. I don't know if anybody from med school remembers rheumatoid nodules, but pay attention on your physical exams, and those with higher levels of disability. And so the slide I put up, because as I was going over the slide, I thought about my patient in clinic and someone else whose mom has RA who wanted to log in today. And they sort of asked me, well, what should I be watching out for? And these are the things, not just for the patients, but for us as a community taking care of these patients. These are the patients that you should be very nervous about. Remember, in the Nurses' Health Study, patients that had had rheumatoid arthritis for longer than 10 years had a 3-fold risk of myocardial infarction or death. So I thought I would start here, and then I said I'll end here. And these are some images that I got from one of my favorite attendings in residency, and probably one of the best rheumatologists in the world, one of the best physical examination old school attendings. And so if you see this in your patients, that means your patients have what we call extra-articular disease. And when RA patients have extra-articular disease, we're in trouble. And that's when I want the cardiology community to take note. So this is an example of a nail fold infarct. So pay attention to the nails. Don't forget to examine the nails. This is an example of digital infarction in patients with, actually this patient I met in Dr. Fart's clinic. This is an example of mononeuritis. So essentially what you're getting is radial nerve palsy until the patients end up not being able to use their hand. Pulmonary nodules. So the pulmonary nodules of rheumatoid arthritis. So remember this, don't forget this image. The ILD of rheumatoid arthritis. I didn't have a chance to talk about all the other manifestations that I wanted to talk about, which made Attila annoyed, but I decided to go with atherosclerosis, but the constrictive pericarditis of rheumatoid arthritis. So this is what I want you to take home. Patients with rheumatoid arthritis die younger. They die younger. The data hasn't changed. Patient with rheumatoid arthritis are more likely to have myocardial infarction than stroke. The data hasn't changed. It's about 70 years old, it's still the same. And don't forget the lipid paradox. Do not be lulled to sleep when you see a normal LDL in a patient with rheumatoid arthritis, or when you see a low LDL. Be worried about those patients. And we end here because, as you know, and I wanted to make this talk about inflammation, which Evan would love, so that we could debate it. He likes to debate Kanakainumab with me. I'm not sure why, on a Friday night. So, so here we are. So I just want everyone to remember that in rheumatoid arthritis, there's a role for innate, right? It's not, there's 2 immune systems at play here. And so we have lots of targets. So hopefully Ray can let me borrow some other people collaborating with him so we can take some people back to the bench, because there's a lot of work to do, okay? And all I wanna say is things have changed in the last 50 years, but progress is not an end result. It's an evolution. Although we have made progress, we still have so much work to do. Thank you so much.
Well, I was going to, first of all, I want to really thank both the fellows for really thoughtful and thought-provoking and really well done presentations. I'm very proud of all the work you've been doing, and we know you're going to change the world. So I have a question to try to pull these two together, which is I'm kind of interested if you, Jackie, talked to Ray about modifying his ASCK with ASCVD.org to incorporate rheumatological features in your program, and how was it handled?
Hello? Okay. I haven't looked through the guidelines to see if rheumatologic, how deeply they address rheumatologic considerations in the guidelines. Because everything that we've done, we tried really hard to stick to the guidelines, so we're not making anything up and being liable for those things. But I think we absolutely should, as Jackie showed, plenty of evidence that it increases cardiovascular risk in the lipid paradox. So we should definitely work that into the ASCVD.org. Yeah.
So I just wanted to say congratulations to both of you. I don't have a question for either of you. You guys are way beyond my abilities in both of those topics. But what I really wanted to say congratulations to both of you about was the diversity of thought and methodologies that you both took, both striving and showing excellence in individual domains that were both creative and obviously passion-filled and added to our understanding, both at a clinical level, but also advancing the science. So I really want to say congratulations to both of you. It's an outstanding job.
May I make a statement? This is Larry Cohen, and I also want to congratulate both speakers. This is wonderful research. I do have a question for the rheumatoid arthritis issues. And thank you. This is a great presentation. And the question that I have, the guru of inflammatory cardiovascular disease is Paul Ritka up in Boston. Would he disagree? Would he agree with this very sensational presentation that you just made?
I'm glad you asked that. I think he and I are 100% on the same page. And I say that because, and I didn't get a chance to go through what is atherosclerosis, because obviously our understanding and definition of not definition, but our understanding of what causes it has changed. And I think that he believes, from reading his work, I don't know him, but I think he believes that there's a larger role of inflammation than we credit in atherosclerosis. And I think if you can learn nothing from rheumatoid arthritis, then use it as a petri dish for inflammation, because I think it backs up that atherosclerosis is a lot more inflammatory than we give it credit for. And again, I didn't get a chance, but the lipid paradox actually, unfortunately, IL-6, IL-1, and TNF alpha also have an effect on lipid biology and lipid metabolism. And actually, it's why those factors are depressed in the setting of active inflammatory disease. And we just don't do a good enough job addressing inflammation in atherosclerosis.
Thank you. I agree with you.
From the era when we first took care of rheumatoid arthritis patients, now there's been a revolution in the modifying agents, which I suspect is also modifying our knowledge. In your experience, and recognizing that it is experiential, still Margaret, others that work in the field, do you modify decisions around your lipid approach based on where people are in their DMA kind of journey? If you monitor ESRs, you monitor CRPs, how can you give us your guidance on that?
That's why you have mentors.
That's a very good question. And we do try to monitor I think having those levels is important to follow it closely, as Jack demonstrated over time. And cannot blend the low LDL, so you have to get it. And piece, then what comes up very quite often in clinic is how to tailor the with some of these, there are some jack
So congrats to both of you. Terrific talks and terrific work. Jackie knows from clinic, I was undoubtedly going to ask you a question here. So, one thing, I'm a little bit of an endothelial centric kind of guy. And so I was a little surprised, and you might want to comment on it, that you didn't mention this, but there's a pretty strong theory in the RA and the autoimmune field that endothelial dysfunction is kind of at the root of the athro. So that's not to diminish the lipid biology part of it, but reducing nitric oxide and cardioprotective factors that are produced in the vessel is really makes the vessel athro prone. And there was a really interesting paper, I think it's probably 15 years ago now, where flow mediated dilation was done in young RA women, and it's very abnormal. And with a month of infliximab, I think it was anti-TNF therapy, it normalized, like completely normalized. So that's
You're stealing my
always,
thunder for my next talk. No,
I just wanted, I'm sorry, I'm sort of going on and on.
Okay.
Maybe you can comment about that, because I think that's sort of potentially at the root of a lot of this.
no, I had a whole, there's just not enough time. But correct.
30 seconds to answer.
Correct. No. So the reason why I talked about the lipid paradox is because people don't know about it. I was in I won't name who, but I was in the CTMR room last week, and I just polled different people, attendings, fellows, and I asked them, what's the lipid paradox? Just because I thought, is it worth talking about? But I mean, of course you're correct, Dr. Bender, but the earliest stage of atherosclerosis we have the data in rheumatoid arthritis patients is endothelial dysfunction, because so if you look at this slide, without cellular adhesion, without the CAMs, you don't get anywhere. And in fact, if we could target the CAMs, then maybe we could change the world and cardiac disease wouldn't be the #1 killer. But it's because you need the cellular adhesion molecules to draw in your monocyte, and then the cells also become more permeable, and then you have LDL that just entered the space, and then the LDL becomes oxidized, and now the monocytes eat the LDL, which creates foam cells. And so that's really, if we can get at the dysregulation of endothelium, if we can get at that moment here, yes, yeah, that's the moment. Yeah.
But it goes back to the disease modifying drug question, and the fact that probably that needs to start as early as possible to prevent the endothelial.
Right. And I think that's why cardio room is the best. Sorry, cardio onc is not here. But I think that's where the field is going, is that cardiologists will actually be involved in the decision making for these autoimmune disorders, because it does change cardiovascular morbidity and mortality. We know that. There's data. I just didn't have enough time to show it. And the JAK inhibitors, that unfortunately has led to a lot of loudmouths in the space, because now it's, well, that's causing cardiac dysfunction. So how do we know that it's not? I think cardiologists need to enter the pool and start treating this disease, because I think that we have the best understanding of the atherosclerotic component. Sorry, no passion. Yes. Thank you. So much stuff I wanted to say. Yes. No. Waiting.
But now you're treating the way to treat the risk about cardiovascular disease.
Correct. And we're not doing Thank you so much.
Thank you, Dr. Velasquez.
Wait. A great eye?
Velasquez?